Hi, welcome to Global Rhinology Network. Today, we are on our visit to the Center of Excellence. It's a journey to excellence, and it's a great privilege to have you, Eric. Professor Eric Wang is a consultant and faculty at UPMC, skull-base surgery, anterior skull-base surgery department, and we along with my colleague Catherine. We had a wonderful 3 days here so far, and looking forward to another day on a UPMC anterior skull base course. So very famous course, and after having this wonderful time, it's a great opportunity to talk to you about your experience in Pittsburgh. So Eric, welcome.
Well, thank you again for making the long journey from England here. We're always honored when exceptional people like yourselves take the time to come to visit us in our little town here in Pittsburgh. But we really very much enjoy these interactions, the chance to get to know you better, and the chance to have these conversations that can hopefully be beneficial to many.
Okay, we would really like to know about the training. It is such a fantastic training opportunities everybody gets from this department. You're training not only your local trainees, but the national, international trainees. So tell me how the training structure in your department is.
So for our residents, we start. We have them quite early. Spend a little bit of time with us when they're first interns in their first year after finishing medical school. But it's a little bit of just an experience, just to kind of get the sense of, what is in the nose, how to use rigid endoscopes, spending a little time understanding some of the basic disease that we encounter. And we also help them when they do their inpatient consults in the hospital, like many. But the real training begins in earnest in our third and fifth year. So most U.S. training programs are 5 years. And so we have them as a junior resident and then again as a chief resident. And what we try to do is very much like many places, we try to do graduated autonomy, where as they prove their knowledge and they prove their commitment to understanding both the patient and the disease process, as well as the surgical interventions that we're encountering, we try to give them growth to become an independent physician. We focus very much in the beginning on the rhinologic sort of surgeries like endoscopic sinus and septoplasty, nasal airway surgery. And as they progress to a chief, more often than not, they start to undertake some of these skull-based cases, like being able to raise nasal septal flaps, pituitary approaches, and septorhinoplasty. So, and then some advanced frontal work is always kind of our hope. Perhaps 4 out of our 5 residents usually get to that point where they're really doing some frontal work. So we think it's a pretty robust system. So I'm the educational director for our team, and I very much believe in trying to provide goals and objectives early on. So when you're a junior resident, I provide those goals and objectives for you. When you're a chief resident, I sort of feel like you should know what you need to get out of the time. So I usually ask them ahead of time to do so. And then we provide reading lists that are reflective of their level. And one of the ways we use assessment is we try at the midterm, around the midterm of the rotation, to have an assessment where we kind of do a mock oral board to kind of get their sense of where they're at. Perhaps there's a little bit of pressure to it, but it does tend to get the reading list done. And then we also do an end of rotation evaluation. And I would say my partners are outstanding with it. I don't do it alone, but both Carl Steinerman and Garrett Chovy do spend the time. We really have to carve out a little time in our schedule, but we think it's a great investment for our trainees and hopefully shows them our commitment to them, and in turn, hopefully their commitment to us and to the patients we care for.
Okay, great. And what stage they decide or they get on to the anterior skull base surgery?
Prototypically as a chief resident. I mean, there's a little bit of work sometimes if you're pretty advanced as a junior resident, but the truth is most of those cases end up being done by seniors.
Okay. Tell us about your own training journey. Did you train at UPMC?
I did not. I did my residency at Washington University in St. Louis. And to be honest with you, I came into rhinology a little bit late. Like I came in with this thought of being an otologist when I was young, and then thought about being a head and neck surgeon, and those are the 2 biggest areas in our training program. And I still remember when I decided I was going to be a rhinologist, one of the attendees was like, "What is that? That's not even a field."
Okay.
So there was definitely some evolution at that time. But there's part of me that always really liked some degree of oncology and being able to provide that degree of care. And so then I went on to do my Rhinology fellowship at the Medical University of South Carolina with Rod Schlosser. It was a tremendous experience in endoscopic sinus surgery and a lot of cellular approaches. And I was fortunate enough then to get recruited here to UPMC at the completion of my fellowship, where I've been since. And this was a real blessing for me because it did give me the opportunity to do oncology, because this is maybe perhaps a little bit of an unusual unit in that our sinonasal cancers are managed by our skull-based team and our rhinology skull-based team rather than our head and neck oncology colleagues. But it allowed me to exercise those things that I really cared about, to be able to do some open procedures in that regard as well. So for me, it ended up being a great balance. And to be honest with you, it's one of the true blessings of my life to be part of this team and to be able to grow here over these many years.
Yeah, interesting. There are so many transferable skills, and quite a few leading rhinologists in the world. They started as an otologist and became a rhinology, including yourself now.
Well, I don't know if I ever became an otologist, and I don't think they want to claim me as such. But but that being said, I do think that many of the things we do, you acquire skills and then you just apply them to what you're doing. Whether that's rhinoplasty or endoscopic sinus surgery. And I'm kind of the funny rhinologist too. Even when I open the nose, I actually still use an endoscope for the posterior portion because I feel like I see better. So I think that we can all be pretty flexible with how we do that, and we learn from each other, and we take some things that work best for us and then translate them to what we do. And then hopefully, like courses like this, we can transfer some of that skill as well.
One of the things that's been evident to us, just being on this course for 3 days and working with you guys, is how much of a team you really are, how you all really get on together, and how involved all your residents and your fellows are with your team. How do you maintain that, and how do you keep that all the time and maintain that enthusiasm for everybody who comes through the department?
It does require effort. It really does. Like teamwork is one of those things that actually a lot of times we may take for a little bit for granted, but you do need to put some active effort into it. The courses do help, because it gives us a time point where we all know we're going to be 4 days together working in a very committed way. I would say another key to our success, and this is just my opinion, is that we publish together, and when a group has a common goal together, a common purpose, it helps bind the team towards a direction. And so we like to think of ourselves as leaders in skull-based surgery. We try to continue to be thought leaders and key opinion leaders in that space. But to do so, manuscripts are really the key to that, I think, to continue to innovate, continue to refine our techniques, to publish our outcomes, to report our complications. And as we do that together, I think it also grows our team together because we review each other's manuscripts, we review the work together, and we look quite critically. And the last part is that there's a logistical portion I shouldn't underscore. This is really the work of Paul Gardner and Carl Schneiderman, getting our schedules to align so we can be in the operating rooms at the same time, see patients at the same time, many of those logistical things. But I would say the last thing that I think has been very important to us is that we critically analyze our outcomes together. We quality check ourselves with a great deal of regularity. A great example is we give ourselves a monthly report on our CSF leak rate at any given time. We use technology to help us report our endocrinology outcomes for pituitary, our rates of readmission, diabetes insipidus. And so we're all very vested then in that center of excellence because our outcomes are being reported to each other, and then have a level of commitment and responsibility to each other. So we try to engineer some things in addition to just putting in effort.
Certainly, as someone who's come in from the UK, we find it really impressive to see how all your data collection is and how good you are collecting all your outcomes and following everything up, and the fact that you all do publish together, because we have many disparate groups across the UK, but not necessarily all working together. And the fact that you can maintain it within a unit is really impressive. How would you manage all that research commitment with the education commitment and the patient care at the same time?
So we're blessed. We do have some resources available to us to help us do so. From very early on, we had a database of all of our endoscopic and nasal approach patients. That's continued to grow and be redefined. We're also very blessed with a really outstanding clinical research coordinator. Her name is Benita Velapidi. And Benita helps us a lot in our organization. Just like Mary Jo helps us with our courses, Benita helps us a lot with our research. So I do think you need some external resources. Surgeons and physicians alone, while I think we give it our best faith effort, we always have to take care of the patient first. And that's always our first responsibility. And sometimes in the midst of that, and that responsibility, we just can't give the effort to do all those other things. So you have to create systems to help you do so. And I would say that all of us do enjoy the process of putting forth new ideas. So that's a recruitment aspect to it too, like people who want to buy into that team structure, who want to buy into that academic productivity and leadership. And so that allows us to then leverage each other's strengths and weaknesses so that we can have even hopefully a better team as we move forward. But it is certainly something that requires some financial commitment and resources in addition to effort and a willingness to do so.
Okay, and what do you see as the challenges going forward, and what is changing in terms of the training programs, in terms of how you manage the department going forward? What are the challenges facing you in the next 5 to 10 years?
Oh, they're always there, right? So I think one of the constant challenges is keeping the team together as much as you're able to, and then training great people in case, if you have really good people, sometimes they get recruited away. So that's one of the big challenges, is keeping our team together. The second is that there's always more and more clinical demand, and finding that balance between the clinical demand and the academics and the education is something you have to be very cognizant of, because it's quite easy to get absorbed into the clinical alone. It's a never-ending pressure as well as an easy fall-in. And so you have to be very committed towards it. One of the things that we try to do is we try to meet on a fairly regular basis to kind of get through those touch points to make sure that we're addressing those challenges. And I would say the last is that, I think education has been great and we love having these courses. But in some ways, we're training all of our people who then go out and take this everywhere throughout the United States, throughout the world. And so we get less consults and we get less patients from all around. We used to, when I first came here, have many, many people fly to us. That's less now, And so it just, it puts the demand to continue to innovate and offer new opportunities for those patients to continue to keep that clinical excellence. But I think that that's a worthwhile challenge. Training other people so that there's a greater distribution of this skill set is actually a really great reward, even though it is a bit of a challenge.
Yeah, that was great on the challenges. So you give me the challenges. So what's exciting in the future, and what are the future things you're looking forward to?
Oh, there's a lot exciting. There's a tremendous amount that's exciting. So I think that even though we have great instrumentation now, there's still a lot of room for technology to continue to help us understand and do things in a better way. The field of radionomics and understanding, predictive things ahead of time is tremendous, right? We're going to have, I think we're going to have larger and larger data sets, and maybe as the NHS, you guys may have this better than anyone, because you'll have these systems where you have large amounts of information. I think that's an exciting time. I think in the areas of oncology, immunotherapy has been a revolutionary aspect, and I anticipate it will continue to revolutionize the things that we do in skull-base surgery from a cancer standpoint. And then finally, I think this balance between quality of life, surgical goals, and the approaches that we use is still an area that we're better at, but we still have room for refinement. And I'm excited to see how this next generation takes the next evolution of endoscopic skull-base surgery to a new place. I hope I still have a role in that. But in either case, I think that the future is really, really bright, because we're still a young, somewhat nascent field, and it gives us a lot of opportunity to refine ourselves and redefine ourselves over and over again. I think it's an incredibly exciting place to be in, both from a skull-base standpoint, but even rhinology, as we're learning this balance between biologics and surgery. And we're really, I think our technology and our new treatment paradigms allow us a lot of room to understand what are the right things to do to help the patient choose the right treatment course for them, and one that also is, to some degree, beneficial for the system. I think we have a lot that we can grow into in that way, and I think it's a great time to be in medicine. There are challenges, as you said, but but I think that there's a lot of opportunity within the midst of challenge.
Oh, that's really good. So thank you very much for that. That's really good. I'll pass back to Ashok to...
So 3 things. What are the key 3 things that you can think of that makes you the leader in skull-base surgery? Global leaders, rather.
So firstly, there's some point about experience. I mean, we want to be able to transfer as much information to each other as possible, but there's still some component of it that you sort of have to do and you live through, right? So we're fortunate to have now over 5,000 endoscopic skull-base cases, and that's given us that experience to be able to share things that are meaningful. I would say the second thing is that we have a really strong commitment to understanding anatomy, and skull-base surgery is in many ways sort of defined by the anatomy.
Yeah.
And as we continue to understand it, research it, look for ways to help us understand these small nuances within these various anatomical subsites we work, I think that makes us better. And I think it makes us more precise surgeons. It allows us to use nuance in many of the ways we provide care. So I think that that's been a real key towards maintaining a leadership role in skull-base surgery. And finally, I would say honesty is actually a really important part, being honest about the things that have worked well for you, and at the same time, to be very honest about the things that have been challenges. Sometimes people criticize us when we talk about our CSF leak rates, or as we learn how to use lumbar drainage and whatnot. They're like, well, I never had outcomes that bad, but they've never reported theirs, And so I think we try to be as transparent as we can be. I hope what that translates into is not just criticism, but an appreciation of the honesty and forthrightness of our team. I hope that is reflective in our team and continues to be an important part of who we are.
Yeah, thank you. That is so important, isn't it?
I think so.
Yeah,
it's kind of the basis of what we do as physicians.
My last question to you.
Yes.
How many hours have you got in your day?
Well, so that's a little bit of a complicated question, I guess. I do have some administrative roles, and I have some governmental funding for research. So it sort of adds to the day a little bit. And, I guess one of the questions that implicitly asks is, what's the work-life balance? Yeah. And so I've found that I like to do my work at work, and I like to be at home with my family when it's time. So maybe my days are a little bit longer, like 11 or 12. But when I'm home, then I'm just home. Like I don't, I try not to check my email ever. Sometimes that makes my partners and my boss mad. But I try to get my work done when I'm here, and then I leave it and then go home and try to be present in my family life. And so maybe it's about 11 or 12.
Thank you so much. It was wonderful to have you and know about all the functioning of the department, the insights, and what makes the department so unique and world leader in specialty. So thank you for your time.
Thank you for coming. Thank you for taking the time. Hope we can continue to work together in the future.
Yeah. Cheers.
Cheers.
Hi, that was a nice, relaxed chat. So I think we really look forward to hear Eric now about his update on olfactory neuroblastoma. So over to you, Eric.
Thank you, Ashok, and it's great seeing you both again. Let me see if I can allow me to share here.
Eric, sounds like we made you do some work from home now. Your work-life balance.
Well, we're still here in the office in our day. You guys are at home, but are you able to see the slides okay?
Yes, we can. Yeah.
Wonderful. Well, I would firstly like to say thank you again for organizing this time. And my partners have shared a lot on anatomy and surgical videos of technique. I'm going to talk a little bit about our research collaboratives, specifically focusing on olfactory neuroblastoma, because it's been an area of some strong interest in our team. And I think we have some nice insights that hopefully we can share. So, we've been interested in olfactory neuroblastoma for quite a while, both in some prognostics as well as some correlation with histopathology. This is an early single institutional paper where we looked at the role of SSTR2, which is becoming an increasingly important part of the management of these neuroendocrine tumors. In our series, we actually found really no significant clinical prognostic value with them. But you can see that almost all of our SSTR2s, which are for this particular tumor type, were expressed. We had very few without. But what it does implicate is the potential for different kinds of therapeutic modulation, particularly that of using dotatate to image in a functional way rather than using solely FDG avidity and glucose uptake. And this is an example of that shown here. Similarly, we looked at some straightforward ratios that often have been prognostic with other solid state tumors. The most classic of this, which is a neutrophil to lymphocyte ratio. And this sort of measures to a degree how much local inflammation is within the tissue and maybe serve as a marker for immunologic response. And as we all know, immunotherapy has become a greater and greater important factor. And what we're able to show in this is that in more advanced tumors, i.e. Kadish C or D, which means intracranial disease versus those without, that they have a higher neutrophil to lymphocyte ratio. So that means there's more inflammation, but less of the preferred lymphocytes that may actually regulate a situation. So this is some early single institutional work that we've done. But really, with olfactory neuroblastoma, it is quite difficult to do this research, even in a high volume center. And I feel like we're fortunate to have a great number of patients who come to see us for this particular disease disorder. So this began one of our research collaboratives. We've talked quite a bit about our proud tradition of wonderful trainees. And so we combine this in something that's often we term the skull-based think tank. So these are individuals who have spent some time in their training at the University of Pittsburgh here, and now are throughout North America. And we group together intermittently to create these research consortiums. And one of our first undertakings was that of olfactory neuroblastoma. Garrett Chobe and Matt Geldseiler helped lead this charge of getting really granular data on olfactory neuroblastoma. And the next works I'm going to present on behalf of the group are really a reflection of that work. So the first thing that we have known for quite a while is that staging of olfactory neuroblastoma is not terrific because it's based solely on anatomy. So what we know about ONB is that in general, the 5-year overall survival is quite favorable. But delayed recurrences and then the consequences of that delayed recurrence can be quite significant. While in overall survival, it reflects that when you start taking time periods out to 10 years. So rather than the traditional squamous cell carcinoma literature, which really focuses on the 5-year time frame, we need to look more distally because a lot of our recurrences can occur late. So these are some of the accepted staging systems at present, with probably the most commonly used is the modified Kadish or Morita Kadish staging system. But the reality is that no olfactory neuroblastoma staging system really correlates with prognosis at 10 years. So we kind of thought, are there ways that we can change that? And this is a great example of the limitations of our current systems. So using Kadish as the example, I think intuitively, most people would recognize that these two tumors are different. And yet, by our staging systems, they are both listed as Kadish C, and then hence grouped together and clumped together in all of our subsequent analysis. One of the most key factors that has come about in the last 15 years has been the concept of the Himes grade. So this is still a subjective grading system, which has a variety of different markers and does require some expertise from a pathologist to understand. But essentially, if you group these lower 1-2 grades with higher 3-4 grades, there seems to be quite a bit of prognostics in regards to disease-free survival, nodal involvement, and also intradural disease. So here's an example of this. When you look at overall survival with a low Himes grade, the Kaplan-Meier curve is favorable over that of a high Himes grade. This is even more stout when you separate these higher Himes grade 4. And then when you look at dural involvement, this is greater when you have a higher Himes grade, So again, suggesting not only more aggressive disease overall, but more aggressive local disease. And then finally, progression-free survival is shown here. So this led to this manuscript. You can see my partner, Garrett Chobe, who will be speaking next, was the first author on this, and our team is all listed here. And these are all, at least one member of the team came from the Pittsburgh lineage. So this had a cohort of 256 patients with, we think, very granular and confirmable data. Again, as expected, with the majority having a high Kadish stage. The neck disease is a little bit higher in this cohort than some of the others, but sort of the expected 60 to 66% are low, while the other third tends to be the high grade Himes by Himes criteria. So when you look at overall survival, a smaller Kadish did have some difference because it's a larger cohort, but the Himes grade really had a similar separation. And so anatomic staging, concurrent with histologic staging, has the potential to help us predict who will do better when we group them together rather than independently. And similarly with distant regional disease. And similar patterns are shown here in the progression-free survival in both cohorts. So this is a way of predicting how good a staging system is. And 0.5 basically means is a coin flip. You know, like if you flipped a coin, you would say it. And you can see that some of our staging systems are not really that much better when you look at these three key areas. But when you incorporate Himes grade, low and high, into this staging systems, now we're able to get some improved separation among these varying groups. And so with this, we proposed the Pittsburgh OMB staging system, which really focuses on the simplest, the Morita-Kadish staging system, incorporating low and Himes grade to give us subclassifications, so 8 total stages rather than 4. And you see that although in the lower ones, we don't really have that high a degree of separation. When you start to get to the higher stage diseases, now the progression-free survival really begins to separate out tremendously. Okay, and one could even argue that a Kadish C with high Himes grade might actually need to be greater than a stage 7, but we use this as our initial foray into it. So going back to the example that's demonstrated here, this is a stage 5 in the novel Pittsburgh staging system, and the hazard ratio for disease progression is 3.6, while this is closer to 9, and that actually much more reflects, I think, the clinical state that most of us recognize and understand. All right. So I think that the incorporation of the Pittsburgh OMB staging system, which uses Himes grade with anatomical staging, allows us to predict these key factors for specifically that progression-free survival with more advanced tumors. All right. So what are the other factors? Well, we know that dural invasion and neck disease are not good portends of outcome. So we began to try to look into this as well. So using this same cohort, Matt Geldseiler, who is in Oregon now and one of our former fellows, really wanted to try to understand who are the patients who don't have any evidence of intracranial involvement on their imaging, but who may actually have occult intracranial disease. And our team has historically resected at least the ipsilateral dura and bulb for all olfactory neuroblastomas because of some anecdotal scenarios. And so we sought to really clarify this particular issue. So we had, of the larger cohort, we had 66 who had no skull-based involvement on imaging, a Kadish A. And 8 of those patients had pathologic involvement of their either their bulb or the dura. So it's difficult to interpret this number. In an ideal situation, this number would have been 3%, and it would probably said maybe we shouldn't resect the skull base when imaging is negative. In contrast, if the number was 40% or 30%, I think it would be quite straightforward to say we should do it in every particular scenario. Head and neck oncology has used the 10 to 15% cutoff number for elective neck dissection for the N0 neck, But this is also a different scenario with intracranial involvement likely being a significant worse portent. So can we dissect into this a little bit more? And not surprisingly, again, Hymes grade came out to be a significant factor. So in the patients who had occult disease, those with higher Hymes grade were more likely to be involved. And interestingly, in those with no intracranial findings, only 1.5% of those actually occurred intracranially. So based on this, I think that patients with low Hymes grade tumors that do not involve the skull base in imaging, it could be considered to decide to do a extracranial surgery entirely without elective skull base resection. I think it's a reasonable, at least, consideration that we should offer the patient. Okay, so what about the neck? This is a multi-center collaborative, actually led by Richard Harvey, trying to understand what to do with the neck. And essentially the conclusion here was the risk factor for primary neck disease was higher Hymes grade, and those with delayed neck recurrences tend to have positive margins. So we started looking into this recurrence issue as well. And 30% of the patients in this cohort had recurrence, at least documented recurrence, with unfortunately the majority of them being local. Okay. And so recurrences were associated with more advanced tumor stage and overall stage, as well as, again, more intracranial disease. But the key things that we could do something about are when pathologic dural involvement is present, and then when positive margins are also present. And the interesting thing about this cohort was that if you start to separate where the disease recurrence occurred, that actually has some prognostic value. So when we manage disease that's local, which is here in the here in the maroon, versus purple, which is in the neck, actually these patients really have improved outcome when you compare it to other intracranial disease, and then the green outline is distant recurrences. So there is a separation depending on when the recurrence occurs that is actually quite important for this particular disease process. Finally, we looked at the role of dural invasion in regional neck recurrences. So Dr. Chobe, when he was at Mayo Clinic, published some work that demonstrated that in that single institutional cohort, that pathologic dural involvement was associated with regional disease. And so we wanted to validate this in this larger cohort that we have available here. This was published just less than 6 months ago now. That really demonstrates this, again, the dural involvement is associated with more significant regional neck disease, and again, correlates with the same recurrence-free survivals. Diving into this, you can see here on the multivariate regression analysis that this was the key factor for regional or neck recurrences, was pathologic dural involvement on the initial resection. So we tried to understand, what is there in those individuals who have neck disease from the onset, do they have worse overall survival? And unfortunately, I think that one of the issues with this is actually, even with this fairly large 9-center cohort, there are not that many patients who have neck disease on presentation. In one of the initial papers we were on, we had 7.7%. In this cohort, 10.7%. So still actually a very small number. So no differences in their recurrences, but their overall survival, if you have neck disease at presentation, was 37.8 at 5, compared to none, which has a more standard 36.7. So we think with more power, as we continue to enlarge these cohorts, we may be able to understand what that prognostic value is in understanding early neck disease, at least on presentation. So with that, I hope I gave you a little interesting overview on some of the research that our team is doing, particularly in this unique cancer. We look forward to more collaborations, and again, thanks for allowing me to be here today.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise. We're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.